So thank you very much, Rina, for your kind introduction. And first of all, I would like to thank the organizer for inviting me to speak today. So, oh, sorry. I have to go back. Oh, okay. So I just would like to declare that I'm HIV clinician. I'm not cardiologist, I'm not psychologist, I'm not endocrinologist, but so because of our patient, they live longer and with the viral suppression, so they can live longer and they tend to have more aging condition or other chronic inflammatory disease related conditions. As you can see here, so we should not be happy just our patient have undetectable viral load, okay? Okay, so the patient meet the U equal U, that's good. But we should think that our patient, they should live longer with healthy HIV, okay? So, so many conditions that can occur frequently and also earlier than non-HIV infection, as Professor Peter Rice mentioned. For example, we usually forget whether our patient had been immunization or not, especially COVID-19, and now for young MSM, whether the country have mpox vaccine, something like that, and another important vaccine like flu vaccine, whether our patient already get it or not. And so I think Rina might expect that I'm going to talk about the mental health because, no, actually, this is important, I think, so especially depression and anxiety and stigma and sexual dysfunction, especially menopause. We usually forget that our patients getting older, they have menopausal symptoms, or they have the problem with their sexual life, and also the substance use and aging related, and with Grace already discussed about the frailty and also mentioned about the sarcopenia. And co-infection, I think is very important, especially tuberculosis. It's very common in this region, okay? And also, it's not happen just in advanced patients. Tuberculosis can occur anytime, so we should think about the tuberculosis as well. And co-infection, especially hepatitis C, in young HIV MSM population. Even though they have negative at the baseline, they can get acute hep C anytime. So we should screen them carefully and also should treat them, not just treat them only, but treat their partner as well. So the majority, I think, the comorbidity. So so I just would like to focus on one of comorbidity. So as Professor Peter Rice mentioned about this study, so you can see that the HIVs appear to accelerate the prevalence of multi-morbidity, so occur frequently and at the early age compared to non-HIV. And when the data from Europe and American cohort, they found that so with this data, the cause of death tend to be more cardiovascular disease and cancer. So as you can see here, the cancer increased from 5% to 20%, and cardiovascular disease is also a major problem. So we need to screen them and need to treat them properly. And also this showing the data show the multi-comorbidity in this population. So I just want to focus on one of my favorite, the cardiovascular disease, even though I'm not a cardiologist. So I think the cardiovascular is unique in the setting of HIV because it's combined between the traditional risk. As you can see, the traditional risk in this population is increasing, right? So if you look at the data, hypertension, so almost 40 or 50% of our patients have hypertension, even they are younger. Just recently published in in Uganda, they look at the prevalence of hypertension in adolescent and young HIV. They found that about 50% of their patients have high blood pressure, and 27% have the hypertension. So it's very high, and it keeps coming up hypertension from Africa, but we would like to see in Asian context. It's not just hypertension, also diabetes is also increasing with the ART. And the hot topic is about obesity. What we're going to do with that? What the sequence of the obesity in this population? And I think another thing, smoking. Have we discussed with the patient enough about smoking cessation? So I think these are the common cardiovascular risk, cardiovascular disease, like hypertension, the coronary artery disease, heart failure, or arrhythmia. If you look at the data, for example, for arrhythmia, the data from REPRIEVE is just published. You can see that they found a prolonged QTc about 9% in men and about 6% in women. And also it's higher in Asian patients, about 12%, especially in Asian men. And also for the patient who have viral load undetectable, have double risk of cardiovascular, of the prolonged QTc. And so many ART that can cause a prolonged QTc if the drug exposure is high. So I think in the future we should have like a optimized, dose optimization for individual patients. And from our cohort, it's also found that the prolonged QT is almost about 20%. So 1 of 5 patients have prolonged QTc. And with the recent data from our cohort show that high sensitive troponin, so cardiac troponin, and it's related to coronary calcium score. So almost half of our aging patients, Thai cohort, have subclinical coronary artery disease, and about 10% of them have severe subclinical coronary artery disease. So they have cardiac calcium higher than 10%. So when we look at the cause of death from the cohort is we have about 12 countries from Asia. So you see that about 6% they die from cardiovascular disease. And when we look at the predictor or the factor related to cardiovascular disease, you can see that older age, hypertension, and abnormal lipid, and also the greater BMI. So you can see this all the traditional condition for cardiovascular disease. And for the cohort data, we projected the cardiovascular disease in this region is double increasing if we don't do anything. Okay, so it's double from 2019 to 2028. So so if we just stop smoking, so you can see that the risk of cardiovascular decreased significantly. And if combined with another intervention like normalized blood pressure, normalized lipid profile, and also substitute lopinavir and abacavir with other ART. So this can close the gap of the risk of cardiovascular disease. And when we look at smoking, you see that, so this data is 10 years ago. So I don't know whether it has changed recently because I don't have the data in recently. So 10 years ago, you can see the Singapore had higher smoker rates compared to compared to Thailand and India. And this population, they have about 20% have hypertension and 8% have diabetes. So this data from DAD study showed that if stop smoking, the cardiovascular risk was decreasing over time. So we should encourage our patient to stop smoking. Just say that, okay, after quit smoking, heart rate and blood pressure drop after 20 minutes. Heart attack dropped significantly after 1 year. Risk of stroke compared to non-smoker at 2 to 5 years. And risk of coronary artery disease declining, so after 15 years. And also, if they can stop smoking before age of 40, so the excess risk of smoking-related condition decreased about 90%. So they have many conditions related to smoking. Not just cardiovascular risk. It's a COPD, it's a cancer, so many cancer, not just lung cancers. So how about the ART? So can we do anything with the ART? Yes. So we have the data from the old data showing that the recent abacavir use was related to cardiovascular disease. Yes, this is also the new data also confirmed that the recent abacavir use increased the cardiovascular risk. So several guidelines recommend that we should not prescribe abacavir to our patient with a high cardiovascular risk, for example, higher than 10%. So recent abacavir use associated with about 40% greater incidence of CVD, okay? And how about the integrase inhibitor? I think the data is conflicting. Some data showing that the increase the risk of cardiovascular disease, but some recent data from Swiss cohort, so they didn't find the difference between the integrase inhibitor and non-integrase inhibitor in terms of the cardiovascular diseases. And the characterized cohort, so this data, I just would like to show that from the advanced study that they compare between DTG plus TDF, right, or DTG plus TAP, and also efavirenz with TDF. So at the week 192, so they found a higher or the greater the weight increase in TAP combination with DTG. And then when they switched the patient to TLD regimen to the characterized cohort, you can see that just only women that have weight loss after switch TAP to TDF. Okay, it's like a gender preference. And also when we look at just recently from the repeat study, I will talk about the repeat later. So they found that just only the patient who start integrase inhibitor less than 2 years that have increased the body weight. But body weight increase is just only, I think it's only minimal, just 2.7 kilo per year. And this group, mainly they use TLD because they are in the resource-limited setting as well. The weight gain, so you can see here, so many data show that the weight gain, so increase the risk of diabetes, okay? Diabetes, hypertension. So I have to go quickly because of time. So just tell you that this is the data from Asia. We see the same thing that the greater BMI is increased the risk of diabetes. And not just that, it's increased the epicardial fat, not just visceral fat. So it's also increased with epicardial fat. What's the importance of epicardial fat? So with this also, with the epicardial fat, so it's increased the stiffness of myocardium, so and increase the risk of heart failure, even they have normal ejection fraction, okay? It's higher in obesity and diabetes. So we should not say that if they have normal echocardiogram, they don't have the risk of cardiovascular, but exactly they have it if they have higher epicardial fat or higher visceral fat. So the data of Thai cohort show same thing, that HIV have higher epicardial fat compared to non-HIV. So these are important. Another condition is about the non-fatty liver disease. So it's common in Asia. It's almost 50%. And for our patients, they have higher progression or rapid progression of liver fibrosis compared to non-HIV. And it's associated with cardiovascular, with cancer, and with neurocognitive, and with other problem. So this, and also for this region, we have we call lean NASH, even though they don't have high BMI, but they can have non-alcoholic fatty liver disease, or they have steatohepatitis. And I just give this, you can see this from the European guideline, how to manage fatty liver disease. And also, just finish by talking about the reprieve, not the whole thing, just summary that for the reprieve study, they enroll HIV patients with low to moderate ASVD score. And so the patient with diabetes cannot be enrolled at that time. And also to enroll them to get placebo or pitavastatin 4 milligrams once daily, and look at so many outcomes. So the study just prematurely stopped last month due to the meet criteria of primary endpoint. So pitavastatin or statin reduced the major cardiovascular disease about 35%. So in this cohort, we have about 15% of Asian in this cohort. But our patients, they have a lower cardiovascular disease compared to others. So we should follow up the final analysis, who should be the best group to start statin in this group. Okay, don't forget to look at the CVD risk assessment. Any formulation have under performance in HIV-infected patients. So when look at the data of predicted and unpredicted, so it's under. Anyway, you have to plus the risk. For example, this is just the example of that, what we should do. At the beginning, I think we should talk to the patient about lifestyle modification and also the smoking. Although it's very challenging, but I think many people think that smoking is the most powerful for cardiovascular disease prevention. So if you are the patient, can stop that, okay? And also using lipid lowering drug if the patient have high cardiovascular risk. And this is the additional intervention beyond suppression of ART. I put smoking cessation is number one. So a key lifestyle factor, diet, exercise, lipid lowering, and address other traditional factor. So A to A, B, C, D, E, S for the cardiovascular disease management. Just conclusion, successful management of person with HIV goes beyond provision of effective ART only, with increasing focus attributed to the appropriate management of comorbidity in order to ensure the best outcome of our patient. Persons living with HIV are twice as likely to suffer MI or stroke even after viral suppression. Cardiovascular risk in HIV patient has a unique, so they have higher traditional risk, have ART, you should modify that, and have the effect of HIV. So improving modifiable ASVD risk factor remain by far the best way to reduce ASVD risk in person with HIV, especially smoking cessation. And stay tuned for the repeat data. And finally, multidisciplinary holistic approach and integration of NCD package in routine HIV care, especially in the region. Okay, thank you very much for your attention. Sorry.